So it's my great pleasure to introduce our first speaker, Dr. Lynn Connolly. She's going to be talking about functional GI disorders and also one of my favorite speakers. I love to hear every time she talks. So Lynn, please.
Good morning. I'm Lynn Connolly. So I'm here at Santa Monica. I see all of general GI, but for various reasons, I luckily get to see a lot of functional patients. So today I was asked to speak about your favorite patient, which is that lower functional GI patient that I'm sure you all love. I've decided to take you through one case and just kind of use that opportunity to go over some hopefully key aspects of diagnosis, workup, and treatment. So this is a 33-year-old woman. She came to me with chronic constipation, abdominal pain, and difficulty defecating. She states that she only has about 1 or 2 bowel movements a week. She strains with defecation. She often feels that sensation of incomplete evacuation, and she has abdominal pain, discomfort, gas, bloating that sometimes improves for a short term with defecation. So, you're a pretty classic patient. She's tried she's one of those patients that says, I've tried everything. Nothing works. And you, as a primary care doctor, referred her for a screening colonoscopy 6 months ago, and it was normal. On review of symptoms, she's got no alarm symptoms. She does endorse TMJ, insomnia, anxiety. She's had constipation pretty much her entire life, and she's also suffered with minor anxiety and depression on and off. She's had 2 vaginal deliveries and no surgeries, and currently she's on a lot of fiber, psyllium husk, flaxseed, chia seeds, and prunes. No significant family history. She's married, she's a working mom, and she does not have any recreational habits. On physical exam, it's notable for she's got some mild left lower quadrant tenderness, but nothing major, no rebound or guarding. On rectal exam, she has hard brown stool in the vault, no blood. You feel that she's got a slightly increased anal sphincter tone. And when you ask her to bear down as if she's having a bowel movement, she had abdominal contraction, but you felt there might have only been partial relaxation of the anal sphincter. So let's stop for a second and ask what is supposed to happen when you're defecating, because it's actually a very complicated process. But assuming your parents didn't mess you up when they were potty training you, three things are supposed to happen. One is the puborectalis muscle, which is that sling that goes from the pubis and around the rectum that's normally tight at rest. That's supposed to relax, allowing the anal rectal angle to increase. Your perineum is supposed to descend about 1 to 3.5 centimeters, and of course your sphincter is supposed to relax. So in this patient, what would you do next? Of course, probably the first thing you would do is get labs. She was convinced, of course, that she had celiac disease and hypothyroid. She had neither, and she is eating a gluten-free diet. So then probably you're asking, should I call GI, or is this something I should be managing on my own? And the question is, the quick answer is you can always call GI. I find that my functional patients are probably my most challenging patients, and I find that if I can collaborate with a primary care doctor, usually it's much more effective than just one doctor, either a GI or a primary care doctor, trying to deal with this patient. But certainly if your patient has any of these alarm symptoms, a GI consult is a good idea because an endoscopy is probably in order. So then, what do you do with constipation? There's a lot of things that you probably ask yourself. First is, what tests? There's a lot of tests out there. Should I be ordering these tests, anal rectal manometry, colonic transit, defecography with or without MRI? On all of my patients, none of my patients? And also, what should I treat my patients with? There's so many things that are out there between fiber, exercise, fluids, laxatives, the new kids on the block, linzess and Amitiza, biofeedback therapy, there's the psychiatric medicines and the psychological therapy options. There's just a ton out there. So what do I do? Well, actually, the first thing that I do is I talk to my patients about constipation, because I feel that most patients have a lot of misconceptions about constipation, and if I don't address that first, then starting with everything else usually is not very helpful. The first thing I address is this concept of autointoxication. Turns out since the 16th century BC, People have been obsessed with this concept. They feel that stool is like dental tartar and it sticks to the wall of your colon and it never comes off. And, I need a cleanse, I have to have my colonic, all of that stuff. And you really have to, silly as it seems, you really have to talk to patients about that. The next thing is patients will come in and they'll say, I had my screening colonoscopy and, the report said I had a redundant or a tortuous colon and that must be why I'm constipated. And so a little key, if you read a report by one of us and it says that it's tortuous, it just means it was a really tough colon to get through. It does not mean that that's why we think your patient is constipated. And we don't recommend surgery for that. Patients are often, they're kind of convinced that there must be some hormonal imbalance. Again, a lot of patients are worried about hypothyroidism. They have weight gain, they have constipation. And yes, obviously, I'm sure you all screen for hypothyroidism on a regular basis, and you probably know yourself that in a patient who's presenting just with constipation, it's pretty rare that you're going to find hypothyroid without some other symptom. Oftentimes, my patients will come to me and they'll say, my doctor just told me that I just need to keep adding fiber and I just need to keep drinking water, and that's why I'm constipated. And, diet, a fiber-enriched diet and water is clearly very critical. However, there's a limit. So, for example, this patient here, she's already on, cupfuls of fiber of various things. And at a certain point, you're just going to end up causing a lot more bloating than you are help. So there is a limit, and yes, everybody has a different threshold, but I think that's something to be aware of. Another thing is fluid. If your patient's dehydrated or doesn't drink fluid or only drinks fluid with caffeine, of course, they need to increase their water intake. But just telling everybody to add, one of those huge bottles and carry it around all day, that's probably not going to do much. And the last misconception that I spend a lot of time talking to patients about is, doc, if I'm on these laxatives, and am I going to get cancer? Am I going to get addicted? Is this really bad for me? And there's no great data to suggest that chronic use of laxatives is going to cause cancer, that melanosis coli is harmful. And it's important to recognize that these are peripherally acting agents. They do not cross the blood-brain barrier. They don't affect dopamine. And so there's no pharmacological basis for true addiction. So after I've kind of gone over some of these misconceptions, then I say, okay, well, now let's figure out why you have constipation. So I try to help the patients go through the different subtypes of constipation. Normal transit constipation is the most common, and it means that the intestinal motility and frequency of bowel movement falls within the normal range, 3 bowel movements a day to 3 bowel movements a week. Your patient can also have slow transit constipation. Defecatory dysfunctions include things like pelvic floor dyssynergia, megarectum, rectocele, abnormal perineal descent. And then, of course, as primary care doctors, you often, of course, think about secondary constipation, which more often than not is medication related. But of course, you have to think about other systemic or structural abnormalities. Especially with these subtypes of constipation, it's important to keep in mind that there may be an overlapping diagnosis of IBS, especially with defecatory dysfunction or secondary constipation, but that's a separate entity, and we'll discuss that in a second. So how do you work up the constipation? I mentioned before all those diagnostic studies and tests and, what should I do? So last year, the AGA released a medical position statement to evaluate constipation. And after, doing a pretty good history, physical exam, baseline labs, they recommend a therapeutic trial of fiber and laxatives. I would add to this that this is a good time, especially in the primary care setting, to assess exercise frequency, fluid intake, and just general diet. It's not in the medical position statement, but I think it's a good time to start to introduce those concepts. If that is unsuccessful, the first test to get is an anal rectal manometry and balloon expulsion test. And I just want to emphasize this. It's not a transit study test. It's an anal rectal manometry and balloon expulsion test. And the reason why is that this changes management. If someone has a defecatory disorder, you're going to do something different than if somebody has slow or normal transit constipation. So if the patient has a normal anal rectal manometry study, then I would argue you could most likely, especially in the primary care setting, just stop there. You can get a colonic transit study to look for slow versus normal transit constipation, but I would argue only in some cases would that really affect your management. Because even if somebody has normal transit constipation, if they're feeling constipated, they're still going to benefit from treatment for constipation beyond just reassurance. However, there are some patients who really need to kind of understand what is going on in their colon. And then, of course, there's the very severe patient, very, very, very rare patient that you would maybe need to do a colectomy, emphasizing very rare. And of course, in that patient, you would want to do a transit study. If the manometry and balloon expulsion test is abnormal, then of course you would diagnose them with the defecatory disorder. And I'm sure Rima is going to talk about that a little bit, but maybe go on to biofeedback. If the manometry study is inconclusive, then the next step is to get a barium or an MRI defecography to again differentiate between a defecatory disorder or slow or normal transit constipation. So in our patient, because again, if you remember the rectal exam, the patient had maybe not complete relaxation of the sphincter, we went ahead and got the manometry study, and this was the result. And I break this up into kind of two main points. The first is that during the bear down command on manometry, she did have complete relaxation, appropriate increase of the intrarectal pressure, and she was able to expel the balloon in 2 minutes. So she does not have pelvic floor dyssynergia. However, if you note here, it took about twice the amount of liquid in the inflated balloon before the patient was even able to sense that the balloon was inflated, and she was able to hold a much larger volume in her rectum than the average patient. And this shows a markedly compliant rectum, which is something you see very commonly in patients who've had long-standing constipation. So again, when you get these results back, you can also look at the thresholds as opposed to just yes or no pelvic floor dyssynergia. So for our patient, first the diagnosis, there was no evidence of a defecatory disorder, but she does have a very compliant rectum, and given her symptoms, she meets Rome criteria for IBS constipation predominant. So what is irritable bowel? Who was here last spring? Any of you were here last spring? Oh, good. I could have given the same talk, but I didn't. That's too bad. Just kidding. So IBS is a symptom complex that basically entails abdominal discomfort that's associated with an alteration in bowel habits. And in the US, women are much more likely than men to have irritable bowel syndrome. And women are also more likely to complain of more severe symptoms, greater intensity of the abdominal discomfort, more extraintestinal manifestations, and worse quality of life indicators. There are 3 subtypes of irritable bowel syndrome: constipation predominant, diarrhea, and mixed. And the important thing to know is that this is based off of stool form and not stool frequency. And this is something people often get wrong. So if your patient's having 3 bowel movements a day, but they're all Bristol stool cell type 1, those hard rabbit pellets, that's still constipation predominant, even though they're having it maybe 2-3 times a day. So I put this in the syllabus just so that you could see it, not so that we could read it all right now. But there are clinical criteria for IBS and functional constipation. This is not a diagnosis of exclusion. And I really want to emphasize that, because I find that a lot of times patients feel that IBS or functional GI in general is something that doctors throw at them when we don't know what else is going on, and that really makes patients nervous. So I often use, especially for example, if I'm going to be doing colonoscopy or some workup and I feel that the patient's met the criteria for IBS, I will say, I am doing a colonoscopy to look to see if you have an additional diagnosis. For example, do you have a colon polyp plus IBS? Because sometimes if you don't phrase it like that, then when they get their negative test results, they feel like, okay, my doctor didn't find anything and she has no idea why I feel this way. So I try to emphasize that this is not a diagnosis of exclusion. That said, I should point out that the Rome criteria don't have the best accuracy to differentiate IBS or any functional GI disorder from a structural disorder. So again, that's why we use alarm symptoms. And of course, as we talked about earlier, you do have to think about other etiologies of their symptoms. So IBS, again, the emphasis that you have to emphasize that these patients have some abdominal discomfort. If they don't have any abdominal discomfort, then it's not going to be IBS. And likewise, if the patient has functional constipation, they have not met criteria for IBS. It's also important to make sure that you have a specific diagnosis. We don't want to call everything IBS. Everything is not IBS. Functional constipation is different than IBS and is treated differently. So what did we do for our patient? Nancy already talked a little bit about diet, and so I thought that I would focus a little bit more on some of the medical therapy options. Even though our patient has IBS, I just want to kind of use this opportunity to discuss the options for both functional constipation and IBS. So just a couple months ago, the ACG task force released the evidence-based summary of medical therapies for both constipation and IBS constipation predominant. And so starting with chronic idiopathic constipation, you can see here that there's a lot of options that you have out there that have pretty strong recommendations. Interestingly, biofeedback was given a weak recommendation, but if you look at why it was given a weak recommendation, it's because it's expensive, not everybody has access to it, a lot of patients are not really receptive to the idea, and not a lot of patients were studied. So even though this got a weak recommendation and the quality of evidence was low, I would say that if you don't look at the entire category of chronic idiopathic constipation, but that subtype that we talked about with defecatory disorder, especially pelvic floor dyssynergia seen on an anal rectal manometry study, that biofeedback is absolutely what I would recommend as probably one of the first line treatments. Now let's switch gears for a second and look at irritable bowel syndrome constipation predominant. So this is not good. There's only one category that had a strong recommendation, and that's ibuprofen and linaclotide. Now, does that mean that every single patient of IBS should be given Amitiza or Linzess? Well, no. So again, with IBS, it's a little bit more complicated because you have to ask, well, why were these given a weak versus strong recommendation? So they use the grade system. So to get a strong recommendation, the therapy has to apply for most patients, for most conditions. Now, for a lot of disease states like diabetes or high blood pressure, yes, a lot of your medicines are going to apply for most patients, for most disease states, or for most situations. But for IBS, it's very complicated. And so I think that it's going to be a lot more difficult to get strong recommendations for every single treatment. So let's kind of break that down. So for example, fiber. Fiber is one of the first things that we all recommend, and it was in the task force guidelines as the first thing to do. However, the reason why it was given a weak recommendation is because it probably only relates to IBS constipation predominant, and most of the studies did not differentiate constipation or diarrhea. And also for the reason that we talked about, which a lot of patients, they have a threshold for what fiber will do. And if you start telling them to add too much fiber, they're gonna be doubled over in pain from the gas and the bloating that the fiber causes. Laxatives, PEG, Miralax was given a strong recommendation for constipation, so clearly it works. So why was it given a weak recommendation for IBS constipation? Because it doesn't help with abdominal pain. So if you have a patient with IBS constipation predominant and their main symptom is the constipation and they're only having bowel movements once or twice a week like our patient, this is still a good choice to start with because their driving symptom is the fact that they're not able to evacuate. If they're having a lot more pain and the constipation is not as much of a problem or it is controlled with fiber, then yeah, Miralax is probably not going to help because it's not going to help the pain. Antidepressants. This is also given a week, which is interesting because if you look at the studies, the number needed to treat for an IBS patient is 4. That's a really good number needed to treat. So clearly these are really effective. But they also have a lot of side effects, and the number needed to harm is 9. Especially with the tricyclics, as you guys know, you're going to get a lot of somnolence, worsening constipation, dry mouth. So for that, as well as the fact that a lot of patients and doctors don't really accept the idea of an antidepressant to treat IBS, it's really limited their use, and that's why it was given a weak recommendation. And finally, probiotics were given a weak recommendation because there's really just insufficient evidence to suggest that these work, again, in all most patients in most circumstances. But if you start to look a little bit deeper with the data, there probably is a beneficial effect, especially for bloating and flatulence. So again, even though IBS is one diagnosis, there's going to be different major symptoms. So if your patient's major symptom is not the pain or the constipation, but the bloating, then this is still a very reasonable thing to try. So what did I do for my patient? So I started her on Miralax, 1 capsule a night, and then I ended up increasing it to 2 doses to 35 grams a day. Eventually, I added a stimulant laxative. So I like to start with osmotic laxatives like Miralax first, because the stimulant laxatives tend to cause a lot of abdominal pain or discomfort. A lot of patients like the concept of an herbal treatment, and so they'll go buy those, scented teas and all of those types of things. So I try to sit down and I go through the differences. And what I often ask people to do is say, let's just try a 2-week period of switching you off the stimulant to the osmotic laxative, and then if you don't like it, we can go back. Or I'll tell people to switch their stimulant laxative from a very strong dose to a weaker dose. And that's where the teas are helpful, because of course you can give yourself a little bit less of a dose. I do find though that a lot of times patients have a max to how much Miralax they can tolerate before they start to feel their stools are sticky, it's too much gas. Sometimes I separate then the dose out. So instead of, for example, taking 2 capsules at night, I'll tell them to take 1 in the morning and 1 at night. And then I also do give people some backup. So for example, when people are more stressed, or especially when they travel, they tend to get more constipated, and that's going to trigger a flare. So I never give somebody just one plan. I always give them a backup of what to do if you're traveling or something like that. And so in this patient, we ended up adding Dulcolax. In other patients, you may just say bring some Senna tea or take an extra dose of Miralax starting 2 nights or 1 night before you travel. I also ask patients to keep a stool diary. The difference between IBS and some of the other disease processes that cause constipation, diarrhea, is that this is very unpredictable. And so patients, if they can keep a stool diary, they can start to learn their patterns and they can adjust the dosage of their laxatives a little bit better. So for a year, she was great. She felt wonderful, and she pretty much had no significant complaints. But then she started to develop more abdominal pain and bloating. She really didn't like taking the medicines, so she kind of stopped taking the Miralax on a daily basis. She usually waited about 3 or 4 days without a bowel movement before she finally took the Miralax, and then she'd get this day of explosive diarrhea. So when I spoke with her, I started to realize that her anxiety and depression were getting a lot worse, not in the form of, major depressive disorder, but just feeling a lot more down. There was a lot more marriage stress, there was a lot more financial stress, and it kind of came on within the 6 months to a couple months before her symptoms started. So this is a good time to stop and think about irritable bowel syndrome as not just a GI condition. Most of the patients who have IBS have extraintestinal manifestations. Chronic pain syndromes are very common: chronic pelvic pain, TMJ, fibromyalgia, migraine headaches, chronic pelvic pain. And there's also a link with depression, anxiety, chronic fatigue, and sleep disturbances. And I would emphasize that as the primary care doctor, this is where I think your role is critical, because if we as GI or primary care only focus on the GI symptoms, the patient's chances of really feeling better is very minimal. So we really have to focus on the extraintestinal manifestations, not just about treating them in the moment, but also realizing that they can be triggers. So for example, in this patient, I think her depression and anxiety was causing a flare, because as we know, when you get anxiety or depression, you can have a worsening of visceral hypersensitivity, and that can knock you into a flare. So it's really important to think about these extraintestinal manifestations at every visit with a patient who has IBS or any functional GI. So what I told her to do was, instead of waiting, and this is really important, instead of waiting 3 days without a bowel movement, start something earlier. Patients don't like taking medicines, but I try to convince them that if you wait 3 days and then take a whole bunch of Miralax and Dulcolax, and then you have that whole day of diarrhea and pain, it would just be a lot easier, and you would take overall less medicine. And I try to emphasize that if you took a little bit every day. brought up the idea of starting an SSRI, low-dose tricyclic, or an SNRI. If I had thought that the anxiety and depression was not the trigger, and I thought that she was just having more visceral hypersensitivity, I would probably have maybe recommended a tricyclic, but I really felt that what was going on had a lot to do with her stress, with her marriage and her finances. So I wanted to bring this up, and I asked her to discuss this with her primary care doctor. And then we brought up the idea of diet. So Nancy brought up the FODMAP diet, and I'm a big proponent of the FODMAP diet. What I will say is this: it's a really tough diet, and I think it's very challenging to try to do this without a nutritionist. So what I usually do is, during the first conversation with the patient, is I try to see if I could make 1 or 2 small changes in their diet and then see how they do. And if they come back to me and they basically haven't even tried that, then they're probably not going to be good candidates to even try the full FODMAP diet. Whereas if they're willing to even just do a 2-week dairy-free diet, or for example, this patient, during the whole visit with me, she had these like thing of mints, and I think she had like 3 mints during her visit after telling me that she had no sorbitol, or artificial sweetener. So I asked her to throw away the mints, and I said, how about you throw the mints away? And she did. And, but it's those like little minor things. And I find that's very helpful before I just send every single patient to a nutritionist, especially since it's not often paid for. You don't really want to waste their time unless you think that they're really going to be willing to do that. I do tend to focus also on just overall health. So are people eating too many calories, too many fat calories? Are they eating a lot of processed foods? Of course, a lot of processed foods have a lot of the sugars that Nancy was talking about. And so I tend to focus more on overall diet during that first visit than jumping right to FODMAP. And then I referred the patient to mindfulness meditation at UCLA. So what is mindfulness-based stress reduction? It was actually developed in the late 70s to bring secular meditation to the Western medical population. It's a non-judgmental focus of attention on the present moment with release of past and future thoughts. And, I think that there are going to be some patients that are going to be open to this and some patients who are not. But I find that if the first time I meet a patient, the only thing I have to offer them is medicine, medicine, and medicine, they're not going to necessarily be receptive unless they're that type of patient that likes to take medicine. So I find it's helpful to, again, broach the concept of the diet and broach the concept to some of these other options that have been shown to be helpful, and then see which direction I think that they're going to go by the end of the visit. So we actually have a mindfulness-based stress reduction program at UCLA, and I think in the lunchroom, Jean Staines is there to go over that in case you want to refer any of your patients with IBS directly. It's a great program. There's a study about a couple years ago that showed about 2/3 of women with IBS showed clinically significant improvement 3 months after the mindfulness-based stress reduction. And this was even better than with the support group. So we know it's not just the fact that they have their meeting. So I sent my patient to the mindfulness meditation program, and I think her quote kind of fit exactly what most of my patients say, which is the training that she received in the class has had a big effect on how she reacts to her IBS symptoms. She stated that she can still get these symptoms, but that she doesn't have as negative of a reaction to them. And that change has drastically lowered her stress and anxiety level on a day-to-day basis. And I think that's very important, because it's not, sometimes the goal for your patient is not to make them have no abdominal pain or, have that perfect bowel movement every morning that we're all still hoping to have, but to just not be so, I didn't mean that personally, but to just not be so upset with all of their symptoms and have that kind of escalate things. After the mindfulness-based meditation program, her primary care doctor started her on an SSRI for anxiety, and as been shown in many studies, it did really improve her global IBS symptoms. She's back to using Miralax 1 to 2 doses a day, and she is doing much better. So just some take-home points. So subtypes of constipation, don't forget about the defecatory disorder. If you're gonna order a study, the study to get is the anal rectal manometry study, not the SITS marker study first. Fiber is great to start with, but just be careful not to give your patients too much, because they're going to cause gas and bloating and more pain. For diet, FODMAP diet is definitely the diet that has been shown, but that doesn't mean that every single patient needs to be referred, there's still a lot that you can do in the primary care setting to get at that FODMAP diet without introducing them to that overwhelming amount of information. Don't forget about the extraintestinal manifestations of IBS. They're often the main triggers for flares, and you can really help that. And then finally, consider thinking outside the Western medicine box. There's a lot of things out there between the mindfulness-based stress reduction, cognitive behavioral therapy, hypnotherapy, and acupuncture. So thank you.